And it's scissors and scrubs time.
Yay.
I'm Nicole.
I'm Laura.
We're sitting here in Laura's basement, waiting for the Bombogenesis to come yet again. Bombogenesis. I woke up yesterday to hear we were going to get a glancing blow, and this morning I was told we're going to get 3 feet of snow.
Yeah, so fun.
And I never work on Mondays, but I'll be working on this Monday.
Yay! We'll be snowed in together.
Yeah, I love it. It's going to be great. So I, again, was not ready for the snowstorm, so I had to go food shopping this morning.
Oh.
But this time I opted to just go to like Stop and Shop. I'm like, I'm not dealing with Market Basket, which shockingly was not terrible. Mm-hmm. Got everything I needed. Going to crock pot them some food on Monday.
Nice.
But I'm really done. I don't want to see any more snow.
So I'm FaceTiming with my son in San Diego yesterday. I'm like, oh, and it's snowing again. And my daughter-in-law, they're coming in 2 weeks. And she's like, oh, I really hope it snows when we're there. I'm like, if it snows when you're here,
I'm going to cry. I literally was walking to work on Friday and I'm looking at the buds. I'm like, the trees are budding.
I thought my trees were budding.
The trees are budding.
Okay.
And like in March, they're going to start tapping them for sap because the sap's going to start running.
Yeah,
they're waking up.
The other day, I was like, is that tree budding?
Right. Why do I hate March? This is why I hate March. Because the flowers are starting to come out. Everything wants to come out, and then it snows on them.
And then steals it from you.
It steals my life away. So that being said, with all the snow in winter, we are going to discuss Mrs. Lindsay Vonn in her Olympic.
Yeah, she tried.
I had very mixed emotions about this because I really didn't think she should be competing. After reading some research, I don't think it mattered whether she competed. I still don't think she should have been competing because she's done. Like when I
list
off,
her last chance.
Yes,
we have very different views on this.
She's had her last chance. All right, she's won golds. Go out on a high note. That's how I am. I'm like, let's go out on a high note.
I know. I'm telling you, competitive people.
I know, and
she would never.
Competitive people, which I am not.
Yes, she would never. She would lay there every night and think, if I didn't try it, but what if I won?
When you read how much she's been through physically.
Oh, no, she's a mess.
She should have hung up her skis a long time ago.
I know. But she's still like one of the best.
She could go down as one of the best with her golds. Like you know, Michael Phelps, that image of him with all the medals on his arms. Imagine if he was like, now he's like 45, he wants to keep going for all the glory, and it would ruin that image if he lost.
I guess
terribly. It's a young person's game.
The golds.
Well, Breezy walked away with the gold this year.
She did.
All right, she deserved it. It's a young person's game. Mm-hmm. All right, Miss Lindsay Vonn. Mm-hmm. Okay, so. In Switzerland on January 30th, it was her final tune-up before the Milan Games. She took a fall that sent her flying into the course's protective netting. Yes. She was airlifted off the course, and her road back to the Olympics seemed doomed. During her run, she was taking a sharp turn, and she lost her balance coming off a jump.
Yeah.
After an off-balance landing, her skis compressed, which put her back and sent her skidding into the net. Mm-hmm. She went down for several seconds, grabbing her left knee and yelling audibly in pain, and she was able to ski down the mountain gingerly before receiving medical attention at the bottom. Mm-hmm. You know what I wouldn't have been doing? Skiing down the bottom gingerly. I'd have cried until you picked me up.
Come get me. This is terrible.
Okay. So after the crash, she puts on Instagram, "This is a very difficult out week. 1 week before the Olympics."
Awful.
But if there's one thing I know is how to do a comeback. Clearly not. So during her February 3rd press conference, she announced that she had completely torn her ACL, which means it is just flopping in the breeze, which we'll get into later. Mm-hmm. Okay? But she vowed to compete in the 2026 Winter Olympics anyway. No. She will be required to race in at least one training session either on the Friday or Saturday before, while the actual women's downhill is scheduled for Sunday. So 2 days before she has to requalify. 2 days. Mm-hmm. Okay. After extensive consultations with doctors, intense therapy in the 1 week before, physical tests, as well as skiing, she has determined that she's capable of competing in the Olympic downhill on Sunday, she wrote on Instagram. Of course, I will still need to do one training run as required to race on Sunday, but I am confident in my body's ability to perform. Mm-hmm. Ominous foreshadowing. Despite my injuries, my knee is stable. I do not have swelling, and my muscles are firing and reacting as they should. because you're wealthy and people can take care of you any the way it should be. I will obviously be continuing to evaluate my medical team on a daily basis to make sure we are making smart decisions, but I have every intention of competing on Sunday. That is what she writes before her Olympics. So, let me give you a list of Mrs. Vonn's injuries prior to the Olympics. February 2006, bruised hip. February 2007, ACL sprain, right knee. February 2009, lacerated right thumb, not related. December 2009, bruised left forearm. February 2010, bruised right shin, broken right pinky. 2011, concussion. 2013, torn ACL, MCL, tibial plateau fracture, right knee. August 2013, broken left ankle. February 2016, fractured left knee. November 2016, fractured humerus bone in right arm. December 2017, spinal joint dysfunction. That's written twice. I don't know why. Maybe it's twice she had it. Maybe it's 2 different functions. I don't know. Okay. April 2024, she has a partial knee replacement. And on January 2026, she tears the ACL in her left knee. She states that after having that partial knee replacement, she was like a whole new woman. She's like, that's what made her
gotta feel better.
Right. That's what made her want to come back and compete. So over the course of her career, which dates back to 2000, she participated in 4 Winter Olympics, enough, and another 21 World Cups. She has 8 Olympic medals, including 2 gold, as well as 84 World Cup victories. In 2016, her 20th World Cup Crystal Globe title won her the overall record for men and women, and she's considered one of the greatest skiers in the history of her sport, male or female. She has accomplished all this while coming back from numerous injuries, including both knees sustained over the course of her high-level career, including her partial titanium knee replacement in 2024. So, Lindsay, hang up the skis. Nope, she's not going to.
One more.
So, on the Friday before the Sunday run, she participated in her first training run and was slightly delayed due to weather. Incredibly, she looked as good as ever during her session. She finished 11th fastest behind Americans Jacqueline Wiles and Breezy Johnson. Her second training run on Saturday was a huge improvement. Laura, she improved on her whole time, a whole 2 seconds, and finished 3rd fastest on the day. 3rd loser. It is not.
That's a bronze medal.
It's still bronze. Nobody talks about the bronze medal winner. They only talk about the gold medal winner. Just saying. I don't. It's not as though the situation is unprecedented. As a skier, she is no stranger to this type of injury. As I've said, she tore her ACL in her right knee and unknowingly raced on it in December of 2013. A situation that ultimately caused her to miss the 2014 Winter Olympics in Sochi. Italian skier Sofia Goggia won silver in 2022 Winter Olympics just 3 weeks after partially tearing her ACL. And down skier Breezy Johnson tore her ACL in 2018. Guess what I'm not doing anymore, Laura? Skiing.
I'm too old.
I need my ACLs in place.
I'm afraid I'm going to fall on my arm.
So we're going to talk about her and then I'll talk about ACLs. So she races. Did not go well. No. So I'm watching the races, all right? And I see Breezy. She nails it. And I leave the room for like 2 minutes and I come back in and Garrett's sitting in there. I'm like, so who raced? She goes, I don't know. Somebody raced and they wiped out. I'm like, well, who wiped out? He goes, I don't know. And then it comes on, Lindsay. I'm like, Lindsay Vonn wiped out? You didn't think? He's like, I don't care. I'm like, holy shit, Garrett, this is huge. Okay, so Lindsay Vonn sustained a complex tibia fracture that is currently stable but will require multiple surgeries to fix properly after a devastating crash in the Olympic downhill. She said in her social post media post on Monday, while yesterday did not end the way I had hoped, and despite the intense physical pain it caused, I can imagine, I have no regrets, Vonn said. 9 days before Sunday's crash, the 41-year-old ruptured her ACL in her left knee, as we spoke about. It is an injury that sidelines pro athletes for months, but ski racers have on occasion competed. She appeared stable in 2 downhill racings. Okay. She wrote yesterday, my Olympic dream did not finish the way I dreamt it would. It was a storybook ending or a fairy tale. It was just life. It wasn't a storybook ending, or a fairy tale. It was just life. I dared to dream and had worked so hard to achieve it because in downhill ski racing, the difference between a strategic line and a catastrophic injury can be as small as just 5 inches. So what happened? Well, she was simply 5 inches too tight on her line when her right arm hooked the inside of a gate, twisting her and resulting in a crash. Her ACL and past injuries had nothing to do with the crash whatsoever, so she states. What is important for people to understand is that the accident that she had yesterday was incredibly unlucky. It was 1 in 1,000. She got too close to the gate, and she got stuck when she was in the air in the gate, and it started rotating. No one can recover from that unless you do a 360. That is something which is part of ski racing. It is a dangerous sport. I still wonder, though, did it have anything? Why did she cut it to? Was it she
Right, were you leaning
she could
more
not
on
rotate?
your right because your
Yes,
left was bad?
right.
Or, yeah.
So from that point of view, I think we can say that she should or shouldn't have participated. The decision was hers and her team to take. She made the decision, and unfortunately, it led to the injury. But I think it's really the way that the decision gets made for every athlete that participates in the downhill. So what is your ACL? We've been talking about it and talking about it. Okay. The human knee has 2 cruciate X-shaped ligaments. One is the anterior cruciate ligament, which is your ACL, and the other is the posterior cruciate ligament. They are the primary central stabilizers of the knee, which is important for rotational stability, meaning if you're turning, like, you're standing, you go to turn to the sink, and that's what's keeping your knee from popping out of joint is your ACL and your PCL. The ACL specifically, I believe it runs kind of through your femur, and it connects the femur to the shin bone. Like when they fix it, they kind of, I haven't done one in 20 years, but I used to do them all the time. And it helps prevent the tibia from slipping in front of the femur. Could you imagine how that would feel? Oh. So if you don't know, your femur looks like if you were to make a fist, and your tibia is flat, and the fist sits on top of the flat plate. The ACL is going to come through the middle of it, and it keeps it from going front and back on that plate. And that's your rotating knee. That's how you walk and how you do everything. You bend, blah, blah, blah. You don't want your femur slipping off of that plate into the front of your
the tibia in front of your femur.
Because that would really feel gross.
Yeah.
So together with the PCL, it keeps the knee stabilized during front to back movements. Okay. Without your ACL, your knee becomes like a sloppy hinge with a lot more rotation. In the athletic community, the ACL is particularly important for pivoting or lateral agility type movements. I was doing a hernia yesterday, and the doctor I'm working with is explaining to the resident about like the movements they can't do as an athlete when they've had an inguinal hernia. So then he's on the phone talking to the mother of this patient. And he's like, yeah, well, he can't do rotating movements, and he can't do this, and and going on and on and on and on. And I looked at the resident. I'm like, if I was that mother, I would have no idea.
Yeah. What is a rotating movement?
I need a list. Give me a list of what he can and cannot do.
Can he bend over?
Right.
Can he switch
and then like in 2 weeks, he can rotate this way. I'm like, does he realize how confusing that is for somebody who's totally stressed out?
Can he make his bed?
Yeah, what can we do here? Okay, so in the athletic community, the ACL is particularly important, as I said, for pivoting and lateral agility type movements. That's why when you hear an NFL player or an NBA player tears the ACL, they are not able to perform the pivoting move. I mean, you see them; they're all over the floor. You can't do that if you're ACL.
The quarterback, when Tom Brady tore his ACL, you can't play. You're running back. You're running side to side. You're diving side to side.
You don't realize how important your knee is in your everyday movement. Yeah. Exactly. So in general, that's why it's important. Ligament, it's the primary stabilizer for high energy activities. All right. So if you tear it, the most common mechanism that tears an ACL is the combination of sudden stop in motion on the leg while quickly twisting the knee, i.e. skiing. The ACL is commonly injured when the skier sits back while falling, which everybody does.
Cool. You don't want to go face first.
Exactly. The modern ski boot is stiff, high, and is tilted forward. The boot thus holds the tibia forward, and the weight of the body quickly shifts backwards. So when excessive force is suddenly applied to the knee, the ACL gets injured. How do you know if your ACL is injured? When the ACL tears, you'll feel your knee go out of joint, and you'll hear a pop.
They all say there's that pop.
I don't want to hear a pop. If he or she stands on the leg, the knee feels unstable, like it's going to give it up. And the knee will swell and expels within 2 hours. Like immediately you're going to have a gigantic knee. And over the next several hours, pain often increases and it will become more difficult to walk. So I think these pro athletes have so much at their disposal to fix things that she probably didn't know it swelled because they gave her medications. They were working on it. Like if you were you or me, we would have had a knee the size of Chicago and we wouldn't have been able to walk. Okay, so what's the initial treatment? You would apply ice and gentle compression to control the swelling. A knee brace and crushers are used. It should be elevated and evaluated by a doctor to see which ligaments are torn and be sure that other structures such as tendons, arteries, and nerves have not been injured. That much swelling can cause nerve damage, which can cause a million other problems. And then you want to take x-rays out to rule out a fracture. If nothing other than the ACL is injured, the knee usually regains its range of motion and it's painless after 6 to 8 weeks. It will often feel normal. You might feel like you have a, quote, trick knee. If a knee does not have an ACL, like you've totally ripped it off, it can give away or be unstable when you pivot or change directions, which would really suck. An athlete can usually run straight ahead without a problem, but when he or she makes a turning motion, the knee will give away and you'll collapse. So treatment, if you were going to have this, you can do non-operative. You can function well even if it's torn. If it's completely ruptured, you probably have to have it fixed. You want to modify activities. You want to avoid high-risk sports such as basketball, soccer, or football. The key to prevent the knee that has a torn ACL from giving out is to avoid quick pivoting motions. Wearing a knee brace can help to prevent re-injury, and the main effect of a knee brace is to be a constant reminder to be careful. The brace will not completely stabilize the knee that has a torn ACL. Exercise can restore the muscle strength, power, coordination, and endurance will help improve knee function and help stabilize the knee. If it has a fully torn ACL, you really might want to think about limited arthroscopic surgery. Many knees in which the ACL is torn have additional injuries, such as a torn meniscus, which is like this little flat piece of cartilage that's between your knee and your tibia. Not your knee, your tibia and your fibia. Nope,
Fibula?
your femur and your tibia. The meniscus. It's in between. It's like a little pad in there. All right. God, Nicole, get it together. So if you have torn your ACL, sometimes the meniscus gets torn. You can have loose bodies and they can hurt when you walk on them.
That joint.
So you go in, you have an arthroscopic surgery, which is they put a scope into your knee and they shave off the parts of the meniscus. They shave off part of the torn end of the ACL. But it does not always help with the instability. You could have a complete ACL reconstruction, which I used to work at one particular hospital and as a traveler. And that's where I was every Wednesday, 7 of them in a row. So I do remember, but it was a long time ago.
They probably do it a little different.
It was in the late 1900s.
Yeah.
So surgical reconstruction of a torn ACL involves replacing the torn ACL with a graft. Sometimes they use cadaver grafts, some they use other stuff. The graft is placed into a position to replace the functioning part of the torn ACL. So you're going to kind of attach it to the part that's still working. The most commonly used graft is taken from the middle third of the patella tendon. Hamstring tendon grafts can be taken from the inner thigh or on the back of the knee are also used, and sometimes cadaver is used. It's done arthroscopically. You don't have to make any huge incisions. They examine the knee. They get through any of the torn meniscus, the loose bodies. They go through all that. The middle third of the patella tendon is used, an incision's made on the leg, and I'm not going to get into how they actually do it, but they'll go in, they'll replace the patella tendon, and they can really stabilize your knee when you get the tendon back. When you do any of these post-op, you have to go through rehab. You have to take it easy on the knee. It's a really bad injury, and I'm still shocked she skied on it.
I know.
I'm going to say that.
But they do.
I know. I am not that person.
The other girl that's
I'd have been kicking it back in the lodge, watching Breezy take the gold.
Oh, I couldn't.
I had my time in the sun.
No,
I'd
good. Have to try.
I am good. So she also fractured her leg. Did she not?
Apparently.
Right. So Laura's going to take it over with the fracture of the leg. And I know most people saw that Instagram post of her in the bed with the erector set on her leg. So Laura's going to take that away.
So supposedly, I mean, all we've seen is that she has a tibial fracture. That is what she did in the Olympic run, is fracture her tibia when she fell.
You don't really see the fall.
No, and she was screaming after. Like the people in the area was saying you could hear her at the end of the mountain screaming, but you don't see.
You don't see.
They took that out.
It was also kind of like on a hill too.
Yeah.
So when she wipes out, you see her clip the gate and then you don't see the rest of it.
Yeah. And then they obviously have a delay in you don't hear the screaming.
Right.
But she was screaming. All she says is that she has a tibial fracture, which is the bone in the lower part of your leg. The X-Fix
says a lot more.
Says a lot more. But I do not know what her actual injury is, because that's all they're saying.
Her X-Fix goes up into her hip.
Yeah. It's her whole leg.
Right.
It's insane. If you can see the pictures online, we obviously don't know what's actually wrong with her, but she has this huge X-Fix on. So I'm going to talk about what an actual X-Fix is. I got this from spine.com.
I got mine from Boston Sports Medicine.
An external fixation is a very, very important tool in the management of fractures in addressing complex orthopedic problems such as limb length discrepancy and severe deformity. So you can use an external fixator for fractures, trauma, and then also like people are born, sometimes their leg is several inches shorter than the other, and they use an X-Fix to lengthen that leg.
X-Fix stands for external fixator.
Yeah. If you have a pelvic fracture, especially from a trauma, an X-Fix is a primary life-saving device.
It looks barbaric, though. It looks barbaric when it's on somebody.
Because it provides rapid stabilization. We stabilize those bones immediately, and they can help stop hemorrhaging. Right. So the technique for putting an external fixator on involves a percutaneous insertion of pins or wires into the bone. And then those pins are then connected to an external frame. This frame stabilizes the fracture or the deformity site while allowing continued access for wound care and soft tissue management. So we put this on. We put these on bones, especially in our line of work. We're usually putting them on a fracture from a trauma, on a leg that is extremely swollen, that's in a million pieces, that we can't go in and put. Like normally you hear people got plates and screws in their fractures. Like, oh, I broke my ankle. I had to have surgery. I got plates and screws. We're putting this on when we can't put the plates and screws in because it needs to heal more. Yeah. The soft tissue is in danger of dying.
Somebody put their car or thought they put it in park. They went to check behind the car. The car runs over them, shatters their pelvis. They're in a pelvic X-Fix.
Right. So
motorcycle accident, external X-Fix.
Yeah. It's usually in a trauma situation for a fracture that we need to watch.
Or you're 40 years old and you shouldn't have been skiing in the Olympics, and you do, and then you end up in an X-Fix.
And I don't know, is the tissue around that area bad? Do they need to watch the soft tissue? Right. They can't let it heal. Was it open? We don't know. Was the fracture? Right. If she had an open fracture, they might have put the X-Fix on.
Both of those areas have had multiple surgeries, so I wonder if that had something to do with it too.
So it's particularly effective in superficial bones such as the tibia, where a pin placement is straightforward. In deeper bones like the femur or the humerus, like you have to go through all that muscle and stuff, the risk of pin track sepsis, like where the pin goes through, increases, and it makes the fixation harder. But for like a tibia or something, it's a great fix. The concept in the widespread clinical use of an external fixation was popularized in the mid-20th century by Hoffman, whose modular systems laid the foundation for the current designs. So we've been using this for over 50 years.
Because he had an erector set when he was a kid.
Mm-hmm. So what are the indications for the use of external fixators? Like I was saying, we use it in trauma and emergency care all the time. Mm-hmm. They temporarily stabilize open fractures. That means your bone has gone through your skin.
It's gross.
Especially when definitive fixation must be delayed. Like if the patient's too unstable to go through a surgery where we can plate and screw their leg because it takes longer, or the tissue around it is dying or compromised, or the blood vessels are compromised. It gives rapid stabilization in polytrauma patients. It provides emergency pelvic fixation to control bleeding and hemorrhage. And it maintains the fracture alignment while allowing wound access and dressing. So if your leg's all mangled up but the bone's broken too, we can throw this on, but we can still take care of the soft tissue around the bone. It can be used for definitive fixation. It's definitive management of fractures, particularly intra-articular or comminuted fractures. And it allows for the stabilization where other methods are not feasible due to severe soft tissue compromise. It can be used in limb lengthening procedures, correction of angular or rotational deformities, bone segment transport to bridge bone defects, and arthrodesis in selected joints. So if you have some sort of deformity in your leg, they will use this to help
Fix it.
And they can also be used for ligamentotaxis, for reduction of intra-articular fractures, positioning of the limb during tendon or nerve repair. So they might put on an X-Fix to move your bones while they're fixing the nerves or something in your or tendons in that area. It can be used for the management of infected fractures, because we're not going to put plates and screws in an infected bone.
Right.
So we can put this on, let it heal, and then permanently fixate it. And it can be used for the stabilization in the presence of extensive burns or soft tissue injury.
Oof. Yep.
The advantages, they have several advantages, particularly in situations where internal fixation or casting is not feasible.
I think it's hard to imagine some of the injuries we're talking about if you've never seen them. But let me
I
tell
know
you,
people like, I had a fracture. It's
you have no idea when some of these legs, the way
they're in pieces.
What can happen to a leg? Let's just say that.
Leg.
In a car accident or something. Like when you need an X-Fix, there's a serious.
They're you see them and you're like,
yeah.
Okay. You take the blanket off and you're like, I'm going to put an X-Fix on.
You're sweating at their pain.
Yeah.
Yep.
Oh, the sight of it. And like nothing torso-wise bothers me.
It's the limbs. Limbs are rough. Fingers.
Yeah. It's pain. It just looks like, oh my God, I hope I passed out.
We had a woman come in one time and she had the whisk from like a KitchenAid mixer on her fingers, and her fingers were woven into the whisk. My butt hurt when I looked at that one. I was like, ooh.
How do you have to hold these legs to prep them?
Yes, they bend in a natural way.
And I was like, oh.
When you lift somebody's legs up and they bend in a way that they shouldn't, and you can hear the bones.
You just know they're in pieces.
You can hear the bones grinding. It's brutal.
Bones are the worst.
I agree.
Anyways.
You go to move a patient, you're like, oh, yep, that leg's broken. Yep.
You can just look at them sometimes.
The way the foot's sitting.
Whoa. That ankle is not.
That's not normal. Yep.
All right. So the advantages: they provide stability and flexibility. It provides rigid fixation in severe open fractures. It allows controlled compression, neutralization, or distraction of fracture fragments. And it enables positioning of the limb for specific surgical or reconstructive needs. These
people are coming back multiple times.
Yeah. Another advantages is the soft tissue and wound management it allows. It facilitates frequent dressing changes without disturbing the fracture alignment itself. Because that
a little zero foam around the pins.
Yep.
A little Acrylex.
But like in that picture that Lindsay Vonn posted, it looks like she has a vac dressing, which is like a sponge that vacuums down, and
it usually goes because the skin cannot be closed. Or literally cannot. There's a piece missing. She must have had which I can't believe she had an open fracture, only because when they show you her on the ground, her tights look fine.
I know, but she also had a huge ass brace on.
That's true.
So I don't know if it's through the brace. I don't know. We don't know what happened to her, but
I don't think we'll ever know.
It looks like she has a vac on. So maybe they just did fasciotomies, which means you cut down, you loosen the fascia.
So if you have a fracture like that, the muscle's going to swell, and the muscles are in like a little casing called fascia. The muscles are going to swell ridiculous, and then they start hitting the fascia, and then the swelling comes in, and it compresses nerves and arteries. So they have to cut the fascia, and they leave these huge open wounds on your legs to allow the. I bet you that's exactly.
So
what
I'm wondering, it was so swollen. It was probably swollen already.
Yeah, I bet you that's exactly what it was.
Did they do fasciotomies and stick a vac dressing? I don't know. Yeah. That's my guess.
Yeah.
But it looks like she has a vac dressing. So
it does.
With this X-Fix, it's going to allow them to change these vac dressings out, because you have to change them out every couple of days.
And they're not going to operate when it's that swollen.
No. But the bone's going to stay right in line, because you have this X-Fix on holding it real tight in a line. And it provides unobstructed access for surveillance of the wounds and limb viability. So you can check this leg
constantly.
The little erectoset sits outside of your leg, like above it a little bit. So you can see all of the skin, the color. You can touch the leg under the X-Fix. It allows for early joint mobilization. It allows it permits limb elevation by suspending the frame if needed. Like if the leg has to be up or the arm has to be up, you can hook the external fixator frame up to like a hanging post so they can be hung up.
It has like bars on it, so you could literally pick this person's leg up like
With
a
the
lunchbox.
bars. That's what we do. Yeah.
It's like,
and it supports early patient ambulation in many cases. It also causes minimal disruption of soft tissues, periosteum, and local blood supply compared with when we fix it internally with plates and screws. There are disadvantages. Pin traction infection is a common. It may progress to deep infection or osteomyelitis. So you're drilling pins into the bone. Like you're literally just drilling right through the skin into the bone. And if you have
any infection or anything into the bone, it is almost a lifelong problem.
Yeah.
It's probably one of the hardest infections to clear up is osteomyelitis.
Yeah. And I mean, but these people are in a position where we can't put plates and screws in because there's probably something
it's
like
one
that.
outweighs the other.
Yeah. You can fracture through the pin tracks, and that can occur after the frame removal. So you put these pins in, and then when you remove it, where those pins were, it can fracture. The device is very bulky and cumbersome.
Gross. Yeah.
And it requires meticulous care and patient compliance. We're going to have to put a picture up, I think, but an external fixator, if you Google it, it is a frame on the outside of your body holding your bones together. So it's big.
It's a connect, so you put pins above the fracture and you put pins below the fracture. And then you use these, what is that composite? I'm blanking on the word, but they're bars that connect the pins. And they have like little couplers to keep the bar and the pin together. So it is like an erector set. If you don't know what an erector set is, it was a toy from the 80s. My brother had one, and you would build these bridges and shit with it. And that's what's on the outside of your leg. Just Google Lindsay Vonn X-Fix and you'll see what's on her leg. It's wild.
And it can also, another disadvantage is joint stiffness may result if the fixator spans a joint. So hers spans
is
her entire
hip to
leg.
ankle. It's hip to ankle.
So she's going to be very stiff.
Yeah.
There's different types of external fixators. There's a unilateral fixator. It's positioned on one side of the limb, allowing functional use while maintaining stability. Common designs of those are monobody frames. They're heavy, rigid designs with intrinsic stability, and pin to bar fixators, which is what we usually use, which are assembled using Shan screws, which are the screws that go into your bones, and then rods and clamps to create a modular construct. So that is what we usually do. We stick the pin in the bone, and then we connect rods and clamps to
all the way down.
Yep, to the next pin. There's circular fixators.
Oh, I've seen those.
You've seen those. They literally encircle whatever limb it is.
I think, did she have some of that on? No, maybe not.
I don't think so. They're constructed from circular rings, tensioned wires, connecting rods, and struts. They provide high versatility and are widely used in deformity correction, lengthening, and bone transport. So those are the ones you're going to see on people that had a deformity in their leg. They're going to put the circular ones on. The trauma ones, you're going to see that unilateral. Just the screws, rods, and clamps on like usually one side of the leg. There are partial rings. They're employed in areas where full ring cannot be comfortably applied, like around your shoulder, your proximal femur, like up near your hip. Like you can't put a full ring around that. So you're going to see a partial ring there. In the Ilizarov fixator is the most well-known example and is the gold.
The Elizaroth?
Yeah.
Elizaroth, yeah.
Ilizarov, yeah.
It's named after some Russian dude.
It is the gold standard for like bone reconstruction. So if you have
that's like bone lengthening.
Yes,
stuff,
if you have a deformity, you're using the
extremely painful.
Yeah. And then this hybrid fixators, they combine unilateral and circular components, and that's useful in situations requiring both stability and fine-tuned deformity correction. So like I said, for the unilateral fixators, which is what you're going to see in a trauma, which is what Lindsay Vonn has, you're going to see Shan screws. They're partially threaded pins. They're self-drilling and self-cutting. You just use a drill, you make a little teeny incision and drill right through into the bone, above the fracture, below the fracture. And then you have rods and tubes. They're available in all different sizes. So whatever length you need, you can get and then you connect those with clamps to the screws that are in your legs. They're carbon fiber
That's what I was trying to
heavy.
think of. Yeah, they're very light.
They're strong, lightweight. They're radiolucent, so that means you can take an X-ray, and it's not like, oh, you got something coming down. You can't see it on X-ray because it's outside, and it's radiolucent.
And if I was scrubbing one of these, all I do is take the X-Fix out and I send it up to the resident.
That's exactly what I do.
Because I have no idea what they're asking for.
You figure out which rod and clamp you want.
You go for it.
And like I said, the clamps connect the rods and the tubes to the screws and to each other. The stability is increased when the screws are, the closer the screws are to the fracture site, the more stability it provides. So you don't want to go way far outside the fracture site.
But you can't get on the fracture site.
The fragment length, the wider spacing of the most distant screws on either side of the fracture improves rigidity. So you want those spaced out to provide the rigidity. Then the rod to bone distance, you want the connecting rod closer to the bone. The closer the connecting rod is to the bone, the stiffness increases. And the dual rod, you can do dual rod frames, and they are more stable than single rod frames. Stability improves progressively from uniplanar single tube frames to triangular or biplanar frames. But bilateral transfixing frames are rarely used today. They stick with the ones we used to do it. You used to remember, you'd see them on both sides, and now they pretty much stay
on one side.
It's just easier for the patient afterwards.
Imagine having all that shit in your leg.
You can get around easier if they're just on one side.
I don't know how she's sleeping because I am a side sleeper. She ain't sleeping on her side with that thing. I would be beside myself.
Yeah. If you're using the rings are just the size of the rings are decided on the girth of your leg or your arm or whatever. Smaller diameters provide greater stability, but they could compress soft tissue. So you have to make sure that you're not using too small of a ring because if it swells,
forget it.
Yeah.
Forget it.
Different size rings can be combined though if you're doing the circular one, like your thigh, you need a larger one, but you can use a smaller one, knee, and so forth. And they want centralizing the bone is preferred, but eccentric positioning has been found to have no adverse effect. So they'd rather it lined up down the middle, but you don't have to, and it doesn't affect the way it heals. The beauty of the fixators is they
work.
Grab and go. Okay, let's make this bar a little bit longer.
Right.
You do it as you go, and it's all on the outside. It's not affecting the bone while you're doing the surgery. You can change your mind and replace it.
It gives them stabilization while the injury calms down, basically.
But it's like an erector set, like you said, so it's not like, it's not perfect. Like you can make it perfect for that patient. There's all different size rods. You can do it, and you can change it, and you're not affecting the pins that are already placed in the leg. And best practice tips for external fixator. You need to use aseptic technique when inserting the pins to minimize the risk of infection. Again, we are going through skin.
You're going into bone.
That's
and
been
bone
damaged.
Does not like
it right into your bone.
Yep.
You're drilling literally from the skin into your bone. Usually we make an incision, then drill when we use an internal fixator. External, we're going right from the outside into your bone. So the aseptic technique is crucial. You have to protect the soft tissue to ensure that there's no necrotic tissue around the pin sites. Pre-drilling the holes helps to reduce bone debris friction and heat generation during pin insertion, which can cause harm to the soft tissue. You have to be anatomically aware of the neurovascular structures near the fracture site, so you don't hurt any nerves or vessels. There are complications. You can get a pin tract infection. That's the most common complication from an X-Fix, and it occurs in up to 30% of patients.
Ooh, that's high.
You also have to think these are trauma patients, so they're just...
but they probably have dirt in there to begin with.
It ranges from minor skin inflammation to deep osteomyelitis, which requires surgical debridement.
Oh, it's awful.
Removal of that part of the bone.
Sometimes they end up with amps. Yeah, like it's not good.
There could be neurovascular injuries. Common danger zones include the radial nerve in the distal humerus, the dorsal sensory branch of the radial nerve near the wrist, and the anterior tibial vessels, with deep perineal nerve in the distal leg. So they had to watch for that.
All of that for her.
Complications include vessel penetration, which was a nightmare.
We don't want vessel penetration.
Thrombosis, delayed vessel erosion, arteriovenous fistula, or aneurysm formation.
Uh-oh.
Yep. Pins placed through tendons may restrict excursion, leading to fibrosis or rupture of the tendon. And muscle tethering may contribute to contracture or loss of function. So you have to watch the muscles and tendons while you're putting the pins in. The X-fix could cause delayed union or non-union may occur, as with other fixation methods. Like it might never get back together correctly. And refracture through the pin sites, like I had said, can occur after fixator removal, which means the post-removal period, you're going to have to be in a cast and all this stuff because now you've caused a fracture on that site. And while fixators allow early weight-bearing and mobilization, prolonged application may result in joint stiffness, muscle fibrosis, or tendon complications, highlighting the importance of pin care site and
Pin care site.
PT.
Oh, yeah.
You obviously need PT.
Nobody wants to ever do because it's work and it hurts. And
no, we'll have to put a picture up on something because just Google X-fix and you'll see there's just rods on the outside of your body.
It's something to see. It's something to see somebody on those. Yeah. Well, I guess we can just leave it at this. We know what happened, so we can sit here and judge and say she shouldn't have done it. Had she pulled it off and took the gold, we'd be talking a whole different story.
In her second training run, she was third. That's still a medal at 40-something years old in the Olympics. Loser. No.
All right.
You a medalist in your 40s.
But it makes me wonder, what if somebody else could have gone in that slot that could have taken the bronze?
No.
All right. I'm just saying.
No.
All right. I think if she had won, we'd be talking a different story, but I think she should have hung up her skis a while ago.
I think she should
have
gone
Lindsay, I know you're sitting in your room listening to Scissors and Scrubs.
Yeah.
Clearly. We wish you the best of health. I hope you get better, and I hope that someday you're actually recreational skiing.
She will 100% be.
I don't know if she'll be ever competitive skiing again. But maybe you can teach little Lindsay Vonns how to ski.
Yeah.
So that is this episode for our Winter Olympics. Dun, dun. I was watching The Cutting Edge the other night. Love it. Topic.
Perfect.
I made my son watch it. He had to begrudgingly admit he loved it.
It's so good.
It's a great movie.
So good.
Topic.
It's my plane movie.
I love it. It's like my go-to. I just love it. I love a good love story. I watched Leap Year the other day too. That's another one of my favorites.
Oh, that is good.
So we are probably going to finish up with a little winter adventure. You're going to love this guy. He's a piece of work.
I'm already cold thinking about it.
Oh, he's an idiot. So we're going to cover another little story next time, and then we're going to move on to some educational shit.
Yeah.
So enjoy, and we'll talk to you in a couple of weeks. Bye.
Like, subscribe, rate, and review the Scissors and Scrubs podcast on whatever podcast app you listen to us on. Follow us on Twitter, Facebook, and Instagram at Scissors and Scrubs. And email us any of your stories or thoughts to scissorsandscrubs@gmail.com.